Hi, good day. My name is Massie and Baling from ANN-BSN2-WIEDENBACH. For today's video, I am going to show you the procedures about nasogastric tube feeding. But what is the definition? It is the installation of specially prepared nutrients into the stomach through a nasogastric tubes. There are 8 objectives. 1. To provide alternate means of ingesting nutrients for patients with functional gastrointestinal tract. Number 2, to intervene in pre-existing or impending nutritional depletion from debilitation. Number 3, to provide aggressive management for certain disease conditions or anorexia. Number 4, to provide means of nutrition if there is an inability to swallow or an existing obstruction in upper alimentary canal. Number 5, to provide nutrients for patient in comatose or semi-conscious state. Number 6, to provide increased nutrient requirements above oral consumptions. Number 7, to provide nutrients for post-operative patients with bowel sounds present. Number 8, to maintain fluid and electrolyte balance. Now, let us proceed to the procedures.
First is to assess client's need for internal tube feedings, impaired swallowing, decreased level of consciousness, head and neck surgery, facial trauma, surgeries of upper alimentary canal. This identifies clients who need tube feedings before they become nutritionally depleted. After that, auscultate for bowel sounds before feeding. Absent bowel sounds may indicate decreased ability of gastrointestinal tract to digest or absorb nutrients. Next assessment is to obtain baseline weight and laboratory values. Assess client for fluid volume excess or deficit, electrolyte abnormalities, and metabolic abnormalities such as hyperglycemia. Internal feeding is to restore or maintain a client's nutritional status, and this provides objective data to measure effectiveness of feedings. After that, verify physician's order for formula, rate, route, and frequency. Laboratory data and bedside assessments such as a finger stick, blood glucose measurement are also ordered by the physician. Tube feedings, laboratory tests, and bedside tests must be ordered by physicians. For the procedures, step 1 is to explain the procedure to the patient because discussion and explanation help allay anxiety, encourage patient cooperation, and prepare the patient for what to expect. After explaining the procedure to the patient, perform hand hygiene because hand hygiene deters the spread of microorganisms. Next is to prepare feeding container to administer formula. Have tube feeding at room temperature because cold formula may cause gastric cramping and discomfort because the liquid is not warmed by mouth and esophagus. Next is to connect tubing to container as needed or prepare ready to hang container. Tubing must be free of contamination to prevent bacterial growth. Shake formula container well, fill container and tubing with formula because filling the tubing with formula prevents excess air from entering gastrointestinal tract. Step number 4 is to place client in high Fowler's position or elevate head of bed 30 degrees. If a sitting position is contraindicated, a slightly elevated right side lying position is acceptable. Elevated head helps prevent aspiration. These positions enhance the gravitational flow of the solution and helps prevent aspiration of fluid into the lungs. Next is to determine tube placement. Aspirate gastric contents to check for gastric residual. Return aspirated contents to stomach unless the volume exceeds 150 ml. Presence of gastric secretions indicates that the distal end of the tube is in the stomach. Residual volume indicates if gastric emptying is delayed. Delayed gastric emptying may be reflected by 150 ml or more remaining in the client's stomach. Next, measure pH of aspirated gastrointestinal contents. Fasting gastric pH is usually equal to or less than 4. It is only infrequently greater than 6. In contrast, intestinal aspirates usually have a pH equal to or greater than 7. Next, observe the aspirates appearance. Gastric fluid is usually cloudy and grassy green or tan or off-white in color. In contrast, intestinal fluid is usually deep golden yellow and is clearer than gastric contents. Consider the results from pH testing and the aspirates appearance together. An aspirate with a low pH and a typical gastric fluid color indicates a high probability of gastric placement. In contrast, a golden-colored aspirate with a high pH indicates a high probability of intestinal placement. Procedure number 6. Initiate feeding. Bolus or intermittent feeding. Pinch proximal end of the feeding tube. This prevents air from entering the client's stomach. Remove plunger from syringe and attach barrel of syringe to end of tube. Fill syringe with measured amount of formula. Release tube and hold syringe high enough to allow it to empty gradually by gravity. Refill, repeat until prescribed amount has been delivered to the client. If feeding bag is used, hang feeding bag on an IV pole. Fill bag with prescribed amount of formula and allow bag to empty gradually over at least 30 minutes. Gradual emptying of tube feeding by gravity from syringe or feeding bag reduces risk of abdominal discomfort, vomiting or diarrhea induced by bolus or too rapid infusion of tube feedings. Next, continuous drip method. Hang feeding bag and tubing on IV pole. Connect distal end of tubing to the proximal end of the feeding tube. Connect tubing through infusion pump and set rate. Continuous feeding method is designed to deliver prescribed hourly rate of feeding. This method reduces risk of abdominal discomfort. Clients who receive continuous drip feedings should have residuals checked every 4 hours and tube placement verified. Next is advanced tube feeding gradually. Tube feeding should be advanced gradually to prevent diarrhea and gastric intolerance to formula. When tube feedings are not being administered, cap or clamp the proximal end of the feeding tube. This prevents air from entering stomach between feedings. Administer water via feeding tube as ordered with diluted formula. This provides client with source of water to help maintain fluid and electrolyte balance. Next is to rinse bag and tubing with warm water whenever feedings are interrupted. Rinsing bag and tubing with warm water clears old tube feedings and reduces bacterial growth. Measure amount of aspirate residual every 4 hours. This evaluates tolerance of tube feeding. Next is to monitor finger stick blood glucose every 6 hours until maximum administration rate is reached and maintained for 24 hours. Alert nurse to client's tolerance of glucose. Monitor intake and output every 24 hours because this intake and output are indications of fluid balance or fluid volume excess or deficit. Next is to weigh client daily until maximum administration rate is reached and maintained for 24 hours. Then weigh a client 3 times per week. Weight gain is indicator of improved nutritional status. However, sudden gain of more than 2 pounds in 24 hours usually indicates fluid retention. Last is to observe the return of normal laboratory values. Improving laboratory values like albumin, transferrin, and prealbumin indicate an improved nutritional status.